Welcome back to Coffee Talk with Janelle and Mike. Today we're going to discuss bipolar disorder as it is Mental Health Awareness Month.
Mhm.
So there's a lot of discussion surrounding bipolar disorder because a lot of people will describe it as mood fluctuation really quickly, and that's actually not accurate. There's a huge difference between mood and affect in a person, and we're going to take some time to discuss that today. And I'd like you to elaborate a little bit about what bipolar is, what it looks like, how it presents.
Okay, so I guess just as Janelle said, we should probably first discuss what we mean by mood fluctuation. So the best analogy and what we learned in medical school is mood is kind of like the climate. So we're filming this from Buffalo, New York, and people around the country know that, in the wintertime, we get a ton of snow and it's really cold here. They don't necessarily know that it's really warm and nice here in the summertime. But
Well, it's not always warm and nice
well,
in the
that's true.
summertime.
That's true, as it's 40 today. But anyways, but mood is a stable period like climate. So your mood is you're happy and elevated over a stable period of time. You're sad and depressed, or a word that we use medically euthymic. You have kind of a steady state of mood. You're neither super happy or super depressed. That's over time. Affect is the moment to moment changes, and that's your daily weather. So in Buffalo, in the wintertime, it may be cold and snowy, and that's the climate. But on any given day, it could be 50 or 60 and sunny. And that is your affect. So moment to moment fluctuation. We all have had times where we've been depressed, but we've still been able to laugh and chuckle at something, or we're really happy but now we're sad because something happened in our life, or we're watching a movie or whatever. So it's important, and the reason why that's important is when we're talking about bipolar disorder, major depression, other things like that, we're talking about sustained changes in mood, not minute to minute changes,
Right.
but sustained changes.
Perfect, perfect. So we talk a little bit about mania and depression, and I'd like you to just spend a little time describing those for folks who don't really completely understand those, and talk about how those relate to the different types of bipolar because there's different variations of how bipolar
Yeah.
presents.
So let's talk a little bit about what a manic episode and really what a depressive episode is. So a manic episode is symptoms such as decreased need for sleep, increased initiative or goal directed activities. These are things like, and often without a lot of positive outcome. So, people suddenly decide that they're going to create a new business, they're going to write a book, and they're spending a lot of time and energy doing it, but they're not creating anything really that's substantial that you're seeing. Grandiosity, feeling that you have special powers, you have a higher level of importance in maybe what you really do in the real world. Increased energy, problems with concentration and focus, agitation, being really fidgety, maybe even being aggressive. Um, the racing thoughts or pressured speech, where your mind's running a mile a minute, and then things like increased behaviors that have a lot of possibility for pleasurable outcomes, but with painful consequences. So increased substance use, hypersexuality. So a manic episode is five of those things over a week for most parts of the day, not moment to moment, but over a week for most parts of the day. A hypomanic episode is three of those things for about 4 days at least. The difference in hypomania is you're certainly elevated and you're above your baseline, but people who don't know you may not know that you're elevated, and it's not really affecting directly your ability to work or social relationships. A depressive episode is, kind of almost the opposite. So you may have increased or decreased needs for sleep. You may have um, feelings of guilt, decreased energy, feeling like you can't really move, and what we call psychomotor retardation, thoughts of suicide, problems in concentrating, slowed speech. And again, you have a handful of these in the case of a depressive episode over 2 weeks. So what we're talking about again, whether we're talking about mania, hypomania, or depression, there's sustained periods of mood
Mm-hmm.
over a period of time to make that diagnosis.
Okay, so can you distinguish between bipolar 1 and bipolar 2?
Yeah. So based on what we just talked about, Bipolar 1 is, by definition, you've had a manic episode, and it's a manic episode that is not accounted for by a medical condition such as hyperthyroidism
Okay.
or substances abuse, cocaine, methamphetamine, things like that, or even medications that we may be taking that aren't drugs of abuse. Steroids for lupus, steroids for asthma,
Sudafed.
Sudafed, things like that that can create a hypomanic or manic episode. So you have an episode of mania, and then you may or may not have also episodes of depression. You don't have to have episodes of depression. Almost everyone does. But a single episode of mania is enough for bipolar type 1.
Okay.
Bipolar type 2 is an episode of hypomania, again, where you're not quite as elevated, typically with recurrent depressive episodes as well. And then there's something called bipolar disorder, NOS, which unfortunately is used incorrectly most of the time. What it means is you come really close to meeting the formal criteria, but you may be missing one. So I said you needed 5 symptoms for mania, maybe you have
Yep.
4, but everything else looks like that. The other thing that's important when we talk about mood states, there is such a thing called a mixed episode. And a mixed episode is where you have at the same time manic symptoms and depressive symptoms at the same time. Very common in children. So bipolar 1, mania with or without depression. Bipolar 2, hypomania with depression. And then bipolar NOS, we think you probably have bipolar disorder, but you don't quite meet the criteria.
Okay, perfect, perfect. So, because it can be difficult to diagnose, because it looks like so many different things, particularly with someone who's presenting with mixed episodes, what would you suggest for a clinician or family members to look for to make sure that we get the appropriate diagnosis?
Absolutely. Well, family members, there's a lot of resources online. There's something called the Young Mania Scale, which you can just Google and get on. There's a bunch of things that you can take. You click off the buttons. It'll give you actually a pretty good starting place as an individual or family member worried if you or someone you care about may have bipolar disorder. The gold standard for all medical and psychiatric diagnoses is doing a biopsychosocial workup, right?
Mm-hmm.
So we're looking for medical causes for these symptoms. We're looking for psychiatric causes, and we're looking at societal and environmental stressors around that may predispose you to these things. We talk about predisposing factors. Genetics plays a large part. So 1% of the population, plus or minus, will have bipolar disorder. If you have a first degree relative, mother, father, brother, sister, with bipolar disorder, it brings you up to about 5 to 10%. Obviously, more family members increases it. But even if you have an identical twin, or you share essentially the same genetic material, it's still only about 50% risk of having it. So, there's a lot of things that go into it. That's why family history is so important.
Yes.
Symptoms are so important. Taking history about substances of abuse and other things like that. Again, about 1% of the population will have bipolar disorder, and we typically can diagnose it late teens, early 20s is most common. There is childhood onset bipolar disorder. It's probably overly diagnosed at this point. But the thing that is difficult is a difficult diagnosis to make at times, and most people who get a diagnosis of bipolar disorder have had symptoms for 10 plus years that have either been untreated, mistreated, or undertreated. So it's a really difficult thing because it's a major psychiatric concern.
Absolutely. And it's important because you don't want to, jump the gun and give someone super young all of these psychotropics, which have a myriad of side effects. But also, it's super important to also intervene promptly if this is happening because of the kindling effect. And this is a phenomena that we've talked about with a lot of psychotic disorders, and also bipolar. And I'd like you to elaborate a little bit if you could.
Yeah. So the kindling effect, I mean, it's kindling, just like kindling wood. So
Mhm.
anyone who started a campfire, you use a little bit of dry wood, and it gets bigger and bigger and bigger. And so it really applies. It actually applies to probably multiple different psychiatric disorders and medical conditions. The ones that we think about most commonly: epilepsy, schizophrenia, bipolar disorder. And what it is in general, it is every episode with respect to bipolar disorder of mania, particularly, every episode that you have predisposes you to more frequent and more intensive subsequent episodes. So if we had a crystal ball and we could 100% guarantee someone had bipolar disorder, we treat it very aggressively. And yes, there are psychosocial interventions, therapeutic interventions, all these other things. But when we're talking about bipolar disorder, we're also really talking about medications.
Absolutely.
That's not true for all psychiatric conditions, but for bipolar disorder, we are talking about medications. If we knew the crystal ball that someone had bipolar disorder, we would aggressively treat them with one, two, and maybe even three medications to control their mood, because every time they have a manic episode, it predisposes them to more frequent episodes, and their long term, lifelong developmental trajectory will worsen potentially with every episode. So early aggressive treatment matters. But just as you alluded to, these medications have a whole host of side effects: weight gain, diabetes, high cholesterol, sexual side effects, making people feel slowed down, movement disorders, all these other things. And so, as with any medical condition or psychiatric condition, it's this risk benefit conversation with your provider, and that only happens if you are having a really good communication relationship with your provider, and your provider both has the time and the thought process to be looking at this globally in a very biopsychosocial model. It's not just about a quick office visit and a prescription.
Absolutely. You need to be well informed, you need a holistic approach, and you need early intervention. All right, folks, that's it for today. Until next time,
Get back
get back
out.
out.